Hello, everyone. We are going to present our Lifetime Achievement Awards now, so if everyone could please stay with us for this important presentation. I am so honored to be here with you all today and to present our inaugural Lifetime Achievement Award from the MDS Foundation. We created this award to really recognize those who have left an indelible mark on the field of MDS. And so today we celebrate more than just a lifetime of achievement, but really recognize legends who have really transformed our understanding of the disease, the treatment and diagnosis of MDS. And so it's my great honor and privilege to introduce Dr. Neimer, who will present these Lifetime Achievement Awards.
Thank you, Peggy Ann. Okay, well, it's my profound honor to present the MDS Foundation's inaugural Lifetime Achievement Awards to two towering figures in the field of myelodysplastic syndromes, Drs. John Bennett and Peter Greenberg. We begin by recognizing the extraordinary contributions of Dr. John Bennett, whose pioneering work has fundamentally shaped the way we understand, diagnose, and treat MDS. Oh, okay, these are, okay. Somewhere there's a slide with Dr. Bennett's picture, but I think, okay, there we go with, yes, and Carol, who have been at virtually all of the meetings together since the very first one in Innsbruck. Dr. Bennett is a visionary in pathology. His groundbreaking work in defining and classifying MDS at the histological and molecular levels have laid the foundation for the field as we know it today. His leadership in developing the French-American-British classification, the FAB system, was a landmark achievement, establishing critical standards for the diagnosis and emphasizing the importance of bone marrow morphology in evaluating MDS. A true innovator, Dr. Bennett was among the first to integrate cytogenetic, molecular, and epigenetic discoveries into clinical practice. His research illuminated how chromosomal abnormalities and epigenetic changes, DNA methylation, contributes to the pathogenesis of MDS, opening up new avenues for the diagnosis and for targeted therapies. As a leader in hematology, Dr. Bennett has been instrumental in establishing clinical guidelines and treatment strategies that have informed care for patients around the world. His contributions have been central to transforming MDS from a poorly understood disease into a scientifically grounded, treatable condition. With over 560 publications, 2 decades as editor-in-chief of leukemia research, Dr. Bennett has advanced the global conversation around hematologic malignancies. His editorial leadership ensured the dissemination of vital new information and cemented his role as a cornerstone of the MDS research community. John's impact extends far beyond the lab and the clinic. As an advocate, educator, and mentor, he's nurtured the next generation of MDS experts and elevated awareness of this complex disease on a global scale. His work with the MDS Foundation has helped drive research funding, improve patient outcomes, and foster international collaborations. We celebrate not only Dr. Bennett's lifetime of achievement, but his legacy of excellence, compassion, and innovation that will shape the future of MDS for decades to come. I'm privileged to serve as the director of the MDS Foundation following John, and I wanted to state just a very brief anecdote that some of you who are in this field for a very long time will appreciate. John Bennett was the authority on the morphology of MDS. And so some of us who were doing clinical trials remember that one of the eligibility criteria for participating in some of the earlier trials was that Dr. John Bennett had to look at the bone marrow slides and decide that the patient had MDS. And that was written into the protocols that the companies would approve. John is, I think, joining us via Zoom. John, congratulations on your award, and we look forward to celebrating many more successes with you, and congratulations on a lifetime of achievement.
Thank you, Steve and Peggy Ann, for this honor, which I'm delighted to receive. I wish I could be with you today, but there comes a time in all of our lives where travel becomes increasingly difficult, particularly overseas travel. So Carol and I have made a decision to restrict our travel to the continental North America for the time being. So I'm talking to you from my cottage in Pittsford, New York State, USA, or 6 hours time difference from where you all are today. So I have just 2 slides to show. One is indicates my mentors in my quest for the profession that many of you recognize, Doctors William Damashek, William Maloney, and Jane DeForge. Jane and both Bill served as presidents of the American Society of Hematology, and both of these were instrumental in my development in hematology at the Boston City Hospital. Henry Rappaport, famous for his lymphoma work from the University of Chicago. I first met when I was in charge of the morphology and cytochemistry section at NIH in the mid-1960s, and Henry asked me to initiate part of the program of the tutorial for neoplastic hematology in the leukemia field, which I participated in for over a decade. Tom Dutcher, famous for the Dutcher bodies, was my mentor at NIH. The institutions that I associated with, Beth Israel Hospital, Deaconess, Boston City Hospital, NIH, and for since 1969, University of Rochester Medical Center. As a clinician, hematology, medical oncology, and a hematopathologist, morphologist, I've always believed that international collaboration was a fundamental responsibility in order to develop and promote a uniform classification prognosis of hematologic neoplasms. From FAB, as mentioned by Steve Neimer, resulted in 13 publications, to MIC, morphology, immunology, and cytogenetics, 4 articles, to the MDS Foundation, IPSS, 4+ articles, to WHO, and now IWMDS, 4 articles. We have succeeded in standardizing criteria for myeloid neoplasms with particular emphasis on MDS. It has been a great privilege to enjoy the academic and social activities of you and so many others around the globe for over half a century, and hopefully for more years to come. As I recall, I have attended in person 16 of the 18 international meetings that we have held, going all the way back to the initial meeting in Innsbruck, Austria. Show the next slide. So my final slide, taken about a year ago, when I celebrated my 90th birthday, acknowledges the contribution of my family. Carol, myself, my oldest son, Rob, and a emergency room physician and associate professor at the University of Rochester. My son, Douglas, a pediatrician. Both their wives are physicians as well. My daughter, Elizabeth, here, who is a adolescent editor, independently working by herself, and 9 grandchildren, none of whom are heading towards being physicians, but one in the upper right here, who is now working on his PhD in atomic physics. So without this group, it is unlikely that I could have achieved what I've been able to accomplish with the help of so many of you. So again, thank you very much for this most important award, which I will share us.
And John, I'm not sure you can see the award, but for everyone in the audience, and the award says MDS Foundation Lifetime Achievement Award presented to John M. Bennett, MD, May 8th, 2025, with deepest appreciation for your lifetime of dedication, innovation, and leadership in MDS. Your contributions have shaped the field, inspired generations, and left an indelible mark on the MDS community. Thank you, John.
Thank you.
We are equally honored to present the MDS Foundation's Lifetime Achievement Award to Dr. Peter Greenberg, whose visionary work has revolutionized our understanding and management of myelodysplastic syndromes. Peter is perhaps best known as one of the principal architects of the International Prognostic Scoring System, the IPSS, first introduced in 1997, which replaced the British classification, the Spanish classification, the German classification, and as John said, by bringing everyone together, created something much more than the sum of its parts. This groundbreaking tool gave clinicians a much-needed framework to assess disease severity and patient prognosis. Dr. Greenberg led the refinement of this model through the revised IPSS, the IPSS-R, further raising the global standard for risk stratification in MDS. With the advent of molecular profiling, Peter again led the charge, conducting some of the first analysis of CD34 positive cells in MDS, and ultimately helping to create the IPSS molecular, which integrated genetic mutations into prognostic scoring, bringing precision medicine to the forefront of MDS care and offering a more nuanced and personalized approach to patient management. Dr. Greenberg has played a central role in shaping the clinical trial landscape for MDS, helping to design studies that explore both novel therapies and supportive care initiatives. His advocacy for trials that prioritize not only efficacy, but patient quality of life has helped transform MDS treatment into a more holistic, patient-centered endeavor. As coordinator of the IWG for Prognosis in MDS, the IWGPM, Peter has led efforts to standardize diagnostic and therapeutic approaches around the world. His work has fostered a global consensus on how to interpret genetic and cytogenetic data, ensuring consistent, high-quality care for MDS patients regardless of where they may live. Peter has chaired the NCCN MDS Guidelines Panel for decades and has helped shape the gold standard for MDS care. His leadership has ensured that evidence-based, consensus-driven recommendations guide the diagnosis, treatment, and monitoring for patients not only in the United States, but around the world. Peter's impact on the field is vast and enduring through his scientific rigor, collaborative spirit, dedication to patient-centered care. He has helped transform MDS from a once mysterious disease into one that is better understood, managed, and treated with clarity. Today, we recognize not only a brilliant mind, but a legacy of leadership that will continue to influence the future of hematology for years to come. Peter, let me welcome you up to the podium and congratulate you on a lifetime of achievement and provide you with this award.
just pushes this forward. Thanks, Steve. It's a great honor. I'm pleased to accept it with much appreciation. Not only has it been a wonderful time to work with this group, but it's been a privilege to work with such dedicated individuals that were interested in sharing a mission, a vision of what we ought to do with this challenging disease. And what I'd like to do is just go back over what's been happening over the past decades in the evolution of where we are now. I'll talk a little bit about biologic evaluation of dysregulation that occurred between the 70s and the 90s, therapeutic modification of hematopoiesis in the 90s and the 20s, characterization of disease heterogeneity that I've been involved in with many people in this room. John mentioned, as did Steve, regarding the issue that many of us have had giants on whose shoulders we've stepped on and who've helped us through various stages of disease. One of them, for me, of course, was my chief of hematology when I was a fellow, Stan Schreier, who was also a president of the American Society of Hematology. As a fellow, one day Stan said to me, "Greenberg, we've got a disease here called pre-leukemia. Why don't you take a look at it?" Interesting thought. Fortunately, at the time, this was when there was the initial development of the clonogenic hemopoietic systems, championed by another individual, one of 4 individuals that was involved with generating the clonogenic systems. This was Don Metcalf. And Don and Ray Bradley in Australia, Plesnik and Sachs in Israel, developed the in vitro colony forming assay in mice, but it was the beginning of hematopoiesis. I was interested in regulation, and dysregulation, of course, was the most dysregulated, was AML. But what about MDS, or what it was called at that time was pre-leukemia? Nearby here, it's ironic that there was an incredible workshop that occurred in '71 in Rijswijk at the Radiologic Biologic Institute by Dick van Beckham, who was a wonderful scientist, Dutch scientist at that time, organized a large group of hemopoiesis individuals, generated much new knowledge in the field. And here's Don Metcalf and a young scientist that was interested in what he had to say. And so I got involved with looking at a variety of hematologic diseases, including this illness called pre-leukemia, and found that the growth of their cells, marrow cells in vitro, was similar to those that in acute myeloid leukemia. And why was that? Either it was because these are pre-leukemic cells that had the potential for more differentiation, or leukemic cells that were somewhat held in abeyance, abnormal to begin with and relapse, and normalized when it goes into remission, and therefore we had the beginning of knowledge of waxing and waning of an abnormal clone, the progeny of which were capable of making colony-stimulating activity. There was no such thing as factors in those days. The only thing we knew about hemopoietic regulation was EPO. And so it turned out, of course, that CSA turned out to be GCSF, produced by those cells in the peripheral blood known as monocytes. And so, as John and Steve mentioned, a critical article that John Bennett was the major proponent came out that started us having at least a name for this disease, myelodysplastic syndrome, in which they looked at the issue of what were the morphologic subtypes. And so we had it. And as a result of having Amgen developing the purified GCSF and the possibility of using differentiation-inducing therapy to think that perhaps by inducing differentiation of a clonogenic cell, you might decrease self-replication of the abnormal cell. We embarked on a clinical trial, 100 patients randomized to receive or to have observation only with GCSF. These were high-risk MDS patients at the time, those with RABE and RABE-T subtypes. And as you can see in bold, there was no difference in the outcome as far as the AML progression in these individuals. However, when one looked at some of the studies that were coming down the road at that time, we saw that there was a major imbalance in risk factors, and particularly in the group that was prognostic score by Sands et al., there was a marked difference in platelet count and a variety of other things, including cytogenetics. When we saw this, the issue was, what are we going to do to try to standardize how we're going to evaluate MDS? So this was where we were, essentially, a Tower of Babel, where many different groups were talking about classification of this strange disease, pre-leukemia. And so, as you can see, people from United Kingdom, Spain, Germany, France, Japan, each had an idea of what part of the elephant they were going to look at, whether it was cytopenias, cytogenetics, age, LDH. And so as a result, at a meeting in Chicago, the third International Symposium, I and a group of people got together, all of those that you saw that were in those initial studies, so that we could coalesce the data. It was already peer vetted, and see what we could come up with. And as a result, the International Prognostic Scoring System was developed. However, as usual, over the next 15 years, again, a series of new factors were being published. Which were the important ones? What was going on? And it became apparent that, again, in a way to try to coalesce what was happening, is to put these factors all together, and we had an international prognostic scoring system that we needed to put the international workshop together again and look to see what were the critical factors. And as a result, with a huge collaboration by many people in this room, particularly Heinz Tuschler, Detlef Haas, Ulrich Germing, Arjan, and numerous others, we developed the IPSS revised, which was involving 11 countries, 7,000 patients, and which was useful. However, we knew that more needed to be done, and over the period of time from 2011 on, there was a period of time in which, again, 5 or 6 groups came up with molecular features suggesting adverse problems. And as you can see, although there were similarities within many of the groups, there were dissimilarities. And as a result, I went back, and this paper here was the critical paper, I believe. Ralph Behar, Ben Ebert, a number of colleagues from Boston put together this paper, and it indicated that it had 5 major mutational abnormalities that appeared to be able to predict risk. After seeing that paper, actually it was an abstract, Ben and I got together, Ben Ebert and I got together and said, we've got to do something about this. We met with a group of people from Celgene to find funding for putting this study together. And at that time, Elie Papiammanuel was moving from Cambridge to New York. And the issue was trying to have a coalescence of what was happening to develop a molecular characterization. And this international working group then came together with studies and data from numerous centers. And there was an oversight committee of which Elsa Bernard, as well as Ellie, were major players, as well as a number of other people, again, in this room that were involved in helping to put the IPSS-M together. And as you well know, this paper, again, with Elsa being the major player, along with Ellie and a number of others, we were able to put together this IPSS-M, which you all well know has been quite useful in current prognostic evaluations. And then, again, with Ellie and Elsa in the lead, began looking at taxonomic features, and again, we find that with this disease, or set of a spectrum of diseases, has 18 molecular subtypes that is critical. And I think one of the problems in the field, we seem to be treating this disease as a homogeneous subtype, particularly the higher risk patients. And so one now needs to consider the use of therapies that might be more molecularly specific. And this just gives you some idea of what is happening with the molecular taxonomic group. These 18 groups, as you've well heard from Elsa and others, has appeared to be quite useful in beginning to look at what are the founder mutations that are involved with the development of this set of diseases. And so there have been a number of different collaborative groups that I've been involved with, trying to put things together for a lot of patients. And so one of the trajectories that we can see over the last several decades is where we've been and where we are. This gives you an idea of some of the explorations that I've been involved in. But coming here to Holland, where a number of the earlier studies that I was involved in was there, there's an interesting quotation, I think, from T.S. Eliot: "We shall not cease from exploration, and the end of all our exploring will be to arrive where we started and know the place for the first time." This just gives an idea of some of the various people and groups that have been supportive of studies with which I've been involved. The MDS Foundation, the board, incredible group of people, very dedicated, amazing idea about mission, and particularly Steve, Sandra Curtin, Pierre Finot, a number of others, Luca Macavali, have been crucial for the development of the system. And without my wife Suzanne and my family, none of this really would have been exceedingly possible. And so I just want to thank the group, the MDS Foundation, for this wonderful honor, and I'm much appreciated. Thank you.
Thank you, everyone. I want to just also spend a moment and thank all of the people involved with the MDS Foundation over the past decades. Acknowledge Tracy Araka, who was the prior director of the foundation, and just to say that we're all privileged to be part of this incredible community. The challenges remain. Peter, your T.S. Eliot quote is very good. Hopefully, with all our exploration, we can get a little bit beyond the beginning, but I think it's still a work in progress for everyone. And I also want to thank the local organizers and not wait until the end of the session and to say that this meeting has already been really stimulating and off to an amazing start. And I want to thank everyone who's in attendance. And we have a little break now, so please enjoy. Thank you.